Okay, it's 12:15. I hope somebody's out there watching. If not, you'll have an opportunity to look at this later if you're interested. We'll go ahead and jump in. Disclosures, I have only this one disclosure. Abbott asked me to speak for them, but they've never invited me. So that's that. I will mention that there is some mention in the slides of investigational therapies, but that'll be clear to you when we get there. So I just wanted to introduce this concept. We've been thinking about this and planning this for some time. So we've envisioned that this cardiovascular corner would be a venue at which many providers in the Heart and Vascular Institute would be able to share information. There are just a lot of new therapies coming, and we haven't really had a way to get out information about what's going on, what new therapies, who you might send for what. And we thought this would be a useful format, so we'll give it a swing for a while. It's designed to be convenient over the lunch hour, 20 minutes of talk, 10 minutes of question and answers. We're not going to do it once a month, every month. We may end up doing 6 or 8 or 10 a year, but it's on an ad hoc schedule. There are a couple that have already been scheduled out there. Ajay Joseph is going to do one on the lifestyle medicine program. Neil Agarwal, that first one is actually going to be about understanding CT angiogram. And there are a number of other topics that we propose. So look forward to having many cardiovascular corner episodes going forward. So I wanted to start out with this, and I've used this slide often. When I started medical school in 1982, the treatments for heart failure were DIG and Lasix. That's all there was. For historical perspective. And then for most of my career, 4 decades of drug study. So you can see all of them listed there. I was an investigator in many of those studies. We've watched them with interest, and that's how we get to modern GDMT is through these 4 decades of drug studies. And that's been the major focus of heart failure therapy for a long time. Late 1990s and 2000s, what I would call the device era begins. Largely focused around rhythm management, prevention of sudden death, as well as CRT, biventricular pacing to improve symptoms. So that's sort of the start of the device era, if you will. But there was a long gap between the 2000s, and then we got MitraClip in 2019 with an amazing 40% reduction in mortality for appropriate patients. But from 2019 to present, there's just been this explosion. And I know this because I go to national heart failure meetings, but incredibly smart people are thinking up wild and crazy and amazing ideas. And there's a huge list of device-based therapies that are coming. So you can see some of them here. New valve therapies for multiple valves, valve replacement in multiple territories. The mitral valve replacement, first device just got approved in recent weeks, for example. There are devices for monitoring to prevent readmissions. There's this category of neuromodulation, some of the other things that are listed there. So there's this huge explosion of device-based therapies. So we begin to think of this as a toolkit. We always start with pharmacotherapy, but then layered on top, there's a whole toolkit of potential devices for management of heart failure. So we're going to focus on a few here. These are therapies that are available here at St. Francis. Some of you may have seen a handful of patients with these, but these will be increasingly used in the coming months and years. So I wanted you to know they're out there, know some concepts about them, and be aware that you may have patients that might benefit from these therapies. So the first category is remote monitoring, and we use the CardioMEMS device currently. So there's a concept for decades. We've taught people monitor your weights, monitor your symptoms, and if we keep a close eye on weights, then we'll keep you out of the hospital. These are randomized trials of monitoring daily weights and signs and symptoms, and there was no difference in heart failure admissions. So non-hemodynamic remote monitoring doesn't work. This is the CardioMEMS device. So this is an implantable device. You can see the size. And putting it in is like putting a Swan catheter out into a pulmonary artery. And while we're there, we drop this pressure sensor. It is simply a pressure sensor. The patient has a device at home that allows them to upload those pressures. And so this is the data. multiple trials of remotely monitoring pulmonary pressures have shown dramatic reductions in heart failure admissions. And 3 of them are portrayed here. And there's actually, I didn't share it here, there's a meta-analysis that actually suggests that in patients with HFrEF, we may actually improve survival by remote monitoring and doing a better job of taking care of their heart failure. So this is a simple procedure. It reduces admissions. Patients monitor their pressures. Our Epic team has been amazing with us. We've actually integrated this. So if you happen to see a CardioMEMS patient, you can go to the Synopsis tab and then click on Cardiac Procedures, and you'll see that individual's pulmonary artery pressures every day that they've sent one. If anything of here is out of range high, it will show up as a red value. The patients themselves can see their pressures. So this is one of my patients in clinic showing me his pressures. And we have a number of patients now who are using those to do physician-directed patient self-management. These are our numbers. And so these were 2 of the randomized trials. This was the rate of admissions per year in the studies. And this is the rate of admissions per year in St. Francis CardioMEMS patients. So you can see our CardioMEMS program has been wildly successful in terms of keeping people out of the hospital. So who might be a candidate for CardioMEMS? Really anybody who seems to be at high risk for heart failure admission. Certainly people with more than one admission. People with a very low EF, even if they've never been admitted, those people are at high risk for admission. People where it's really hard to assess their volume status. Somebody with COPD and heart failure calls in and says, I'm more short of breath. Well, if it's their COPD acting up, we don't want to double their Lasix and drive your creatinine up. So these are people that may benefit from CardioMEMS. When we think about who does well with CardioMEMS, we need to think about compliant patients, people sharp enough to use this system at home, people who can take a phone call to adjust medicines. So those are some concepts about the CardioMEMS and who might be a candidate. I just put this up. This is an investigational device. We're going to be in a national trial starting, I think it'll be this will be this summer. We're going to start implanting this device, which goes in the IVC instead of the pulmonary artery. But again, another way to monitor fluid status and detect fluid buildup before patients become symptomatic. Oh, I didn't realize there was a video there. So that's how simple that is to put in. So that's the CardioMEMS device for remote pulmonary monitoring. This is cardiac contractility modulation. So this is a device that was FDA approved in 2019. It has been available at St. Francis since 2022. It looks a lot like a pacemaker. Indeed, it's a pulse generator implanted on the right side, has a couple of leads, but that's where the similarity ends. This isn't a pacemaker. It doesn't alter heart rate. What it does, this is a EKG down here. If I deliver a signal right here halfway between 2 beats, we're going to get an extraventricular contraction. But this device delivers a signal right here immediately after the R wave. And so that's in what we call the absolute refractory period. So there's no pulse, there's no contraction. And because it's here, not over here, there's no proarrhythmia. So that's how the device works. Well, what does it do? Why is that going to help somebody with heart failure? It turns out that for reasons not entirely understood, delivering that electrical energy right at that moment in the cardiac cycle alters things that happen at the sarcoplasmic reticulum. So I'll take you back to medical school. We learned there's this area of the cell, which is a storage for calcium. And with each beat, the sarcoplasmic reticulum dumps calcium into the cell, and that's what creates contraction. So the more calcium that gets dropped in, the stronger the contraction. So something about the CCM therapy dumps more calcium into the cell each beat, and it also takes it back up faster. So it has both an inotropic effect and a relaxation effect. So what do we know about CCM therapy? This is looking at VO2. So this is a cardiopulmonary exercise test. This is subjective quality of life, the Minnesota Living with Heart Failure, New York Heart Association class, and 6-minute walk. All of these go up with CCM to a magnitude equal to or greater to than what patients get with biventricular pacing. So CCM therapy has been shown to improve symptoms of heart failure in appropriate patients. We don't have data to say it improves survival, but we have solid data to say it improves symptoms. So candidates for CCM are people who've on medical therapy and they still have class 3 symptoms of heart failure with EFs in this range. Those patients are candidate for CCM therapy to improve quality of life. Even patients with a defibrillator in place can still get a CCM on the opposite side. So that's CCM therapy. And this is neuromodulation. There is a device called the Barostim. So here's the case for neuromodulation. And this has to do with what we've known for many years. We would refer to the neurohormonal hypothesis of heart failure. So in people with heart failure, we've known for decades that many different neurohormonal systems get revved up. Those neurohormonal systems change genetic transcription at the cellular level. They promote remodeling, enlargement of the heart, and specifically high catecholamines, high sympathetic tone, is associated with increased mortality and worsening heart function. At the same time as sympathetic tone goes up, parasympathetic tone goes down. And all of that is why beta blockers improve survival. So beta blockers decrease mortality by 35%, improve EF, reverse remodeling. But we all know that beta blockade is incomplete, and the majority of patients only receive a fraction of what we would consider a full dose of beta blocker. And so this is the case for, is there another way to protect the heart from this constant adrenaline flogging that promotes progressive worsening? And so that's what neuromodulation is, and specifically this device that has the brand name Barostim. So I tell patients the body has multiple thermostats that it uses to sense and estimate blood pressure. And if the body thinks blood pressure is high, then it's going to turn down the adrenaline level. And one of those blood pressure thermostats is the baroreceptor on the carotid artery. So this device, again, looks like a pacemaker. Again, it's implanted on the right side, but instead of having a lead that goes to the heart, there's a lead that goes up and is tacked just on the outside of the carotid artery. So this is a minor surgical procedure. Our vascular surgeons, Dr. Weber and Dr. Guerra, do this for us. It's an in and out same day procedure. And it turns out that then delivering electrical therapy here at the baroreceptor fools the body, thinks blood pressure is high, and starts dialing down those adrenaline levels. And so we think that this is a mechanical electrical way to do more of what beta blockers are intended to do. So what do we know about what Barostim therapy achieves? That is shown here. So similar metrics to what I showed you with CCM a minute ago. Here's exercise capacity in a blinded randomized trial. So this was the control. Their exercise capacity actually got a little bit worse. In Barostim, their 6-minute walk distance improved. Their subjective quality of life metrics improved markedly compared to control, and their New York Heart Association class improved. So once again, this is advice. We still don't have mortality data. We still don't have hospitalization data, but we do have strong data to show improved symptoms. We have about 25 of these implanted in the St. Francis system, and about 3/4 of those patients have portrayed to a significant subjective symptomatic improvement. So that's the Barostim device. So Barostim candidates are EF below 35%, class 3 symptoms, or sometimes recent class 3, now class 2. Those people would be potential candidates for Barostim therapy. The next therapy I'm going to talk to you about is another device-based therapy. It is investigational. The trauma surgery team, Dr. Goodwin and Schellenberger and Katsas, are going to be working with us on this research study. It's called the RECOVER-HF study. And I put up here this image. I want you to think about the process of pulling a rubber band back and then popping it, letting it go. So that's the concept behind this device relative to heart failure. And in this case, the rubber band is the diaphragm. So the heart sits right on top of the diaphragm. We don't think about it often, but there is definitely an interaction between the diaphragm and intrathoracic pressures and cardiac function. So this device is a simple laparoscopic implant. The implant takes about 40 minutes. One lead goes up here, which is a sensing lead so that it can sense the cardiac cycle. And this is a stimulation lead. When you look at the diaphragm below the heart, you can actually see where the apex is. The surgeon can see it tapping, and he puts the lead just adjacent to the LV apex. When you send in a signal on this lead, it contracts a very small area of the diaphragm, small enough that the patient can't even feel it. But when you stimulate this, it draws that part of the diaphragm down, and then when you unstimulate it, that part of the diaphragm pops back up. So the concept is it's time to the cardiac cycle. We stimulate during diastole, it pulls the diaphragm down. That improves diastolic filling of the ventricle. And then we release stimulation, the diaphragm pops back up, and it's like that rubber band pop at the time of systole to improve cardiac output. So here's what the data on preliminary studies have shown in a pilot study. They've shown improved quality of life, very similar metrics to what I showed you with Barostim and CCM, improved 6-minute walk, a little bit of a bump in EF, and amazingly, a 17% increase in cardiac output when they turn on this device to deliver synchronized diaphragmatic stimulation. So this is a study that we anticipate starting to enroll patients in, and patients will be implanted on this sometime in the next few months, thanks to help from our trauma surgery team. So we're very excited about this particular research study. So I'm actually getting farther along faster than I thought, which is good news. So to summarize what we've talked about a number of devices. I really wanted people to have the perspective that this really is a new era of implantable devices for heart failure. I like this concept of a toolkit. So again, we start with pharmacotherapy, but then there are many device therapies that we can layer on top. Every FDA-approved device-based therapy for heart failure is available now at St. Francis. And as I showed you, we've got about 5 or 6 research studies going on in the heart failure clinic. And so investigational devices, that new remote pressure sensor, this synchronized diaphragmatic stimulation are devices that will be in trials. We have a lot of trials going on. And sort of a message is that across the whole spectrum of heart failure patients, low EF patients, mid EF patients, people with normal EF, there are research studies that we have going on in the HFpEF space. All of those people, if they have lifestyle limiting symptoms, I still can't play golf, or I'm short of breath walking down the street. Those are all people that we would likely have something to offer in heart failure clinic, either with an approved device therapy or optimization of pharmacotherapies, or in some cases, some of these research studies we're involved in. As you think about referring patients to heart failure clinic, I would ask for a little bit of common sense. Look at the overall perspective of the patient. Is this somebody that we really think heart failure clinic is going to be able to meaningfully help? Think about age and frailty. Consider comorbidities, people not like to live much longer anyway, patients who are going to be compliant with therapies. But if there are patients out there with persistent symptoms, would like to do better, be able to do more, and meet some of these criteria, we'd love to see them. I wanted to show you that referral process. This is new in Epic not long ago. So now if you type in ambulatory referral to cardiology clinic, you have the option just to do general referrals. Some of our outreach sites are listed here, but there's an option down in the corner to refer that patient to heart failure clinic. So I want you to be aware that that's available to you now. Just as a final wrap up, we've done a lot in the heart failure space over the last 3 years, and I've been privileged to lead sort of relaunch of a heart failure program that we hadn't had for a number of years. We've been climbing up this flat slope, but just right now we're at an inflection point, and the program is going to take off to new levels. This is one of our LVAD recipients. When we were doing LVAD patients back in the 1990s, this is what it looked like to have an LVAD then. And this is what a modern implantable LVAD looks like. So patients with these devices are out living a quality of life. You've probably seen some of them walking around in Walmart and didn't know it because their batteries and drive lines are tucked up under their shirts. We launched a new LVAD program just a little over a year ago. November of 24 was our first LVAD implant. And importantly, Dr. Hernandez just joined us recently. We've been trying to recruit somebody like Dr. Hernandez for 3 years. And really, I'm going to still be in the mix to a great degree, but he's the new director of the heart failure program for the system. And so I wanted you to be aware that he's out there, get to know his face, and we'll try and get him in front of you in one of these cardiovascular corner sessions in the future. And with that, I'll stop right here and we'll go to questions. If there's anybody out there that has a question, feel free. And I'm just going to put up the QR code. For CME, you can scan that code. And if for some reason it doesn't work, there'll be an email coming out with that QR code for you as well. So we have a few minutes for questions if there's anybody out there.
If nobody else has a question, I was wondering if you could talk more about the trials that the Heart and Vascular Institute is doing. Any that you didn't mention?
Yeah, so we have that CCM device is currently approved for people with low ejection fraction, but I mentioned that CCM therapy appears to promote better relaxation, which makes it a promising therapy in the people with normal ejection fraction heart failure, these people who have stiff heart muscles. So that's a study called AIM Higher, and we're the number 6 enrolling site in the country for that. There is a procedure to put in an interatrial shunt site. We were in Responder. That study just closed. We were the number 2 enrolling site in that. There's a study upcoming to look at Barostim, again, for people across the EF spectrum, to try and prove a mortality benefit. That's called Benefit HF. We'll be in that soon. Study of that implantable IVC monitor. There's a device on the inpatient side for diuretic resistance patients, a device that's implanted in the IVC just above the renal veins that can promote diuresis in people who are diuretic resistant. And there's a handful of others. So the Heart Failure Clinic has been a hotbed of the development of a new research department that Cliff asked us to work on the first month he was on campus. So there's a question in the chat, any contraindications to having these devices? So the answer is, in general, people can have these devices even if they have a defibrillator or a pacemaker. So many of our patients who get Barostim or CCM do have a defibrillator on the other side, and that's not a contraindication. CCM is not allowed if somebody has a biventricular device for reasons that I won't go into. But they can certainly have those devices over there. Somebody with bilateral carotid stenosis, we would vote not to poke around on their carotid artery to put in a Barostim. So each of the devices individually might have their contraindications, but there aren't a lot of those. So again, if you have people out there with EFs in these ranges, Sudip, I hear that comes from you. If you got somebody you think, I wonder if they might benefit from device-based therapy, if they seem like a compliant patient who's healthy enough that they could stand to benefit from heart failure improvement, we'd be happy to see what options are open to them among these different device-based therapies, either approved or investigational. Very good. Shall we just stop early, Allie?
Sounds good, yeah.
We'll let everybody get back to their afternoon office on time. For once, I didn't go overtime.
Thank you, everyone.
Thanks, everybody. Have a great day.